Well, good afternoon, everyone, and thank you for attending this special web event for diabeteshealthequity.org. We are the Partnership for Diabetes Health Equity, a project made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myers Squibb Foundation Together on Diabetes initiative. Healthcare reform has created an opportunity for medical systems to move towards a population health focus of integrated care, combining three critical elements: clinical care, community engagement, and data collection and analysis to drive improvement. Where early evidence is emerging that integrated care is possible and that patients achieve better health outcomes when they're managed this way. Well, how is this possible, you may ask, to transform care to this model, and exactly what does it look like? Well, I am very excited to welcome you to this webinar to announce and discuss our upcoming learning collaborative based on this three-element model of comprehensive diabetes care. My name is Sabrina Jackson, and I am privileged to serve as the co-director of this project along with Dr. George Rust. Today our format will vary just slightly. I will moderate as usual. Dr. Russ will begin the presentation to give you an overview of the three-element model of comprehensive care and set the tone for what we're seeking to achieve in the Learning Collaborative. Then I will join him towards the end to give you specifics about the collaborative design, dates, qualifications, and etc. So why don't we begin with his bio? Dr. George Rust is a professor of family medicine and the co-director of the National Center for Primary Care here at Morehouse School of Medicine, where he has taught and led various programs since 1991. Prior to that, he served 6 years as medical director for the West Orange Farm Workers Health Association in Central Florida. He is board certified in both family and preventative medicine. He previously served as board chair of the Atlanta Community Access Coalition and co-chair of Georgia's Minority Health Advisory Council, where he led development of the Georgia Health Disparities Report in 2008. Dr. Russ is the author of over 80 peer-reviewed publications related to primary care, health disparities, and underserved populations. His career as a family physician and scholar has consistently focused on primary health care for those in greatest need. As Dr. Russ presents, we will entertain questions at the end, so please jot them down and then submit them at that time. However, during the presentation, if you have any technical issues, then feel free to type them in the Q&A box. So, ladies and gentlemen, without further ado, I bring you Dr. George Rust.
Well, thank you so much, Sabrina. Thanks for letting me be here with you today. And what I would like to spend a little time talking about is reviewing this three-element model that is the heart and the core of what we teach regarding strategies for achieving health equity, and particularly diabetes health equity in communities all across America. Remembering that disparities and inequalities on the day after, actually 2 days after Martin Luther King Day, we can remind ourselves of his quote that of all the forms of inequality, injustice in health care is the most shocking and inhumane. And what we're looking for specifically are equality in health outcomes. Equality in services may not be the goal because some people may need different services, different ways of reaching them than others. But equality in outcomes is when we start getting toward health equity. We just have to remind ourselves that that's not where we're at right now. There are significant disparities in diabetes outcomes across the country, and if we just look simply at hospitalization rates for uncontrolled diabetes per 100,000 population, we see the top bar on this graph is for the African American population. The next line is for Hispanic, and the lines clustered at the bottom for white and Asian sectors of the population. And you can draw similar graphs for low income versus high income, or low education versus high education. The bottom line is we're not achieving equal outcomes or equity in diabetes. So that's the goal. How do we do it? And remembering that Health disparities are a complicated business. There's lots of stuff going on that range from people's own healthcare behaviors, their own healthy behaviors and unhealthy behaviors, the context in which they live, social determinants, poverty, education, and so forth, as well as the healthcare system and how well it serves different segments of our population, both access to care as well as quality of care. So all of these complexities is what we're trying to deal with, both to overcome the challenges as well as to play on or build on the resiliency factors in communities in order to achieve health equity in diabetes. We've boiled this down into a 3-element model that we think is critical for achieving health equity. A lot of us work inside a clinic. We take care of patients, we wear white coats, we do doctor stuff or nurse stuff, and that's our frame of reference. But of course our patients live out in the community, and that's where a lot of the health outcome behaviors happen. And so we have to think about both venues, both environments, as places where we can make a difference. And then usually somewhere over in some other place there are people who are measuring outcomes data, measuring hospitalization rates, emergency room visits, and so forth. And those data don't always get back to us in the clinic or in the community. What we'd like to talk about today is both the 3-element model, but paying special attention to those green arrows, the connecting the dots piece of this model, because they may be even more important than improving care and outcomes within each silo of clinic and community and outcomes. Connecting clinic with community, connecting the outcomes in feedback loops back to the clinical people or back to the community folks, all of which are critical and are really in a lot of ways harder to do. Let's focus on these 3 elements: clinical practice transformation to improve diabetes care and outcomes, person, family, community engagement, treating patients as free-range humans who live in non-clinical settings and make autonomous decisions, and then finally these outcomes data feedback loops. Let's look at all 3 and particularly pay a little bit of attention to what's between these 3 elements. First of all, in clinical settings, let's just remind ourselves that we ain't perfect. We have a long ways to go in achieving what would be considered quality of care for people with diabetes, whether it's in Medicaid or Medicare or even commercial populations. Our ability to achieve good A1C control is less than 50% in most populations that have been studied, so we have a long way to go. In other industries, they measure quality by defects per million opportunities. This would be counted as more than 500,000 defects per million opportunities in terms of our ability to achieve the highest possible outcomes of good A1C control. Now, how do we do it inside the practice? There are there's a huge literature around quality improvement interventions inside clinical practices. We're not going to spend a huge amount of time on that today, but just to remind us that a lot of things that people do really only work a little bit for a little while. This notion that you do report cards and give feedback to providers, for example, it scores a 1.43, a odds ratio of 1.4 in terms of improving quality relative to doing nothing, as opposed to organizational change or systems change that got a 10-to-1 ratio of improvement. So it's significant that patient reminders are better than doctor reminders, but changing the workflow and changing the process of care is way better than any of those things. Here's an example. We did this project at one of our community health centers here in Atlanta. Southside Healthcare is one of the largest federally qualified health centers in the South. When we looked at their process of getting from an abnormal A1C, actually deciding to order an A1C and then getting all the way to doing something about it, we counted 8 different discretionary steps where somebody had to do the right thing in order for the good outcome to happen. So if we go all the way from the patient gets a finger-stick blood sugar, they may have fasted, the doctor sees the patient, they may or may not order a hemoglobin A1C test, If they order it, the patient may slip out the back of the building, or they may choose to go to the lab and may wait long enough to get their blood drawn. When the results come back 2 days later, the doctor may notice that the A1C is elevated, may ask the staff to call the patient back for a follow-up. And again, these may be doctors, nurse practitioners, physician assistants. When that happens, then someone tries to get a hold of the patient by phone. The patient may agree to come back, might actually keep that appointment once they make it. And then if they come back, the doctor may intensify the regimen, or a clinician may intensify the regimen. A lot of the steps don't have to be discretionary if you redesign the workflow. And so that's what we did, which was to create a standing order protocol that, just like we do a finger stick glucose on every diabetic patient who comes in the door, we started asking them to do a finger stick A1C level using an immediate cartridge. In those days, we were using a DCA 2000 machine. You can also do it now with cartridges that are sold over the counter, the A1C Now cartridges. But having the A1C then available on the chart at the moment that the clinician walks in the room to see the patient. Clinician and patient then can discuss the A1C level right then in that moment of opportunity. And then you get to the step that ought to be discretionary, which is the clinician may intensify the regimen. That's really the only step that needs to be discretionary here. And so the idea is that changing workflows means resetting the default setting to do the right thing automatically unless the clinician says no. Most of our clinics right now are set up in a way that the default is don't do anything unless the clinician orders it. And so flipping the switch on that, do the right thing automatically unless the clinician says no or the patient says no, then radically changes your outcomes. And in this clinic, they changed their average A1C from 8.55 before the intervention to within about 6 months, it was down to 7.84 across their whole diabetic panel. So that's really quite a striking improvement in a fairly short time by making good care automatic. Inside the clinic, we also try to empower more people to do more things. We want our medical assistants and nursing assistants to be able to order preventive services tests for people, for example, with standing orders. And more we're using group visits and thinking about not just one patient at a time in the exam room, but a whole panel. How are all of my diabetics doing? In your clinics, for example, can a clinician pull up a record of all their diabetics and say, what's the average A1C level of all my diabetics? How many of those diabetics have an A1C that's wildly out of control? Show me all the people that have an A1C greater than 9. Beginning to think of our patients as groups of patients in a panel rather than just waiting till they come in the exam room and reacting to what they do one at a time. That requires teamwork. That means doctors can't be the whole story. Doctors, nurse practitioners, and PAs together can't be the whole story. We need everybody on the team doing their job together and everybody working up to the level of their license to be able to provide best practice care. So that's all inside the clinic. But, and of course, inside the clinic, we also need to think about above the neck issues, because if you have depression, or nervios, or susto, or any other kind of anxiety, substance use, any other kind of above-the-neck problem, it's going to complicate your diabetes management, and both need to be managed together. And we need teams that are able to do that. Of course, our patients don't live in our exam rooms where this magic of the doctor-patient visit or the clinician-patient visit happen. They actually are free-range humans, and they roam the countryside doing all kinds of things that they don't ask our permission for. So we think about a patient-centered medical home, but people don't live in these homes, hopefully. That's where the clinicians live. The patients live in actual homes. And we have to think about what goes on in that community piece of the three-element model. How can we help people in their daily lives in the context of family and community? Here's why that's important. We talk about preventing the complications of obesity and diabetes. Well, all you have to do that is to modify a person's health beliefs and attitudes, daily habits, eating preferences, daily activities, exercise habits, grocery stores, neighborhood walkability, food advertising, self-care, employability, economic empowerment, access to medical care provider quality, and medication adherence, all in the context of his or her family and social relationships. I used to be able to do that in one breath. The point is, it's a ton of stuff. you can't possibly address those issues from inside an exam room. And so it takes focusing on the community and building partnerships with community stakeholders for them to help solve many of these issues. One way that we begin moving in that direction is to partner with community health workers or promotores to have peer counselors, people with diabetes who are in and of the community, help other people with diabetes in that community. And there's a good evidence base that suggests that this model works significantly for various chronic diseases. But we also need to partner with the community to solve bigger problems, whether it's food deserts and getting a grocery store in the neighborhood, whether it's creating a neighborhood food garden, just as the people in this picture are building a water pipe in the middle of Honduras to try and bring fresh water to their village. Those of us in urban areas of America may need to work together to build community gardens or to recruit a neighborhood grocery store or a farmer's market to come and bring produce into our neighborhoods. But the model suggests that there are three elements, and if we're not careful, we think about the clinic piece and the community piece, again, as separate. What we really need to think about is that big purple arrow right here in between clinic and community. How do we connect the dots? How do we knock down the clinic walls as a barrier between what goes on in clinic quality improvement and home and community-based interventions that could improve outcomes? So let's focus on that for just a quick second. It's obviously a huge area, and I'm not going to be able to cover everything here. But when you think about those group diabetes visits or those patient education sessions, who says they have to happen in a clinic? Why not in a church basement? Why not in the middle of an orange grove where workers are gathering before they start their workday? There are a lot of different ways to think about community-based settings for things we think are clinical that could begin to get clinical people interacting with community people and knocking down the walls of the clinic as a barrier between those two settings. In Anchorage, Alaska, the South Central Foundation, which is an Alaska Native-owned organization, actually builds their teams inside the clinic with community individuals represented on those teams. And specifically, they have not only a clinician, like a nurse practitioner or a doctor, plus a behavioral health specialist, psychologist, or social worker, but they also have a native healer, a traditional healer, on that primary care team, actively engaged in collaborative care of the patient panel that they're serving. That's a great way to knock down the clinic walls and integrate what's happening in the clinic with what's happening in the community and to provide a real collaborative care model where all of us are working together to try and get people to the best possible outcomes. Well, when we think about that model again, there's that third element of the outcomes themselves. How many of your clinicians actually know what their uncontrolled diabetes emergency department visit rate is? How many of your clinicians know what their hospital admission rate is per 100 diabetic patients? How many know what their leg amputation rate is, or how many cases of blindness they've had among their diabetics in the past 5 years? Most of us don't have those active feedback loops that really tell us how we're doing, and most of us don't really have a handle on, is that different for Latino versus Anglo patients in our practice, or Black versus white patients in our practice? So there's much work to be done on trying to get these outcomes data back to the clinicians in a panel-based or population-based format so that we really know how we're doing in a big picture for all the people we take care of. That means community-level metrics like mortality or hospital bed days, practice-level data. Do we know when our own patients are ending up in the emergency room, and do we add them all up at the end of the month to kind of see if that's fewer than last month? And then, of course, with electronic health records now, there is the possibility of creating person-level feedback where I get an alert if a person doesn't refill their metformin or their insulin, or if they had an ED visit yesterday and I should give them a call. All of those things would be examples of connecting the dots between outcomes, maybe at the hospital level, and clinical practice in the primary care setting. And what we need is better connectedness so that we have feedback loops that really tell us how we're doing in that space. Patient-centered medical care and patient-centered medical home guidelines, PCMH guidelines now, really emphasize this, that we know what's happening when our patient hits the emergency room or is in the hospital before they get discharged. Are we communicating with those settings? Are we coordinating care? Are we managing between the lines? And that's a challenge now for most of us in primary care, to build that connectedness between us and those outcome settings. And so a lot of the things I'm talking about today are things that we all find a little hard, and that's what the Learning Collaborative is going to be all about, is bringing champions who have figured out some of this stuff together with people who are wannabes like me, who want to figure out how to do it better and are willing to try some things that the champions can teach us in our own settings to make care and outcomes better. And particularly in the three-element model, not only trying things inside the silos, inside the clinic, inside the community, inside the outcomes data, but between those silos, so that we're connecting the dots between clinic and community, connecting the dots between clinic and outcomes, and even connecting the dot for that outcomes data between that kind of reflection of how are we doing as a community in terms of health data back to the community. What you're seeing on your screen is from the OASIS data system that our public health department runs here in Georgia. It's an online screen. I call it democratizing the data, where anybody can go in there and see how is their county doing by race, by gender, by age group on indicators of health or adverse health outcomes. How does it compare to the state of Georgia? How does it compare to other groups? And in a way, it sort of lets people who are not professional epidemiologists or biostatisticians actually kind of get a feel for how are we doing. And are these community interventions? Did the community garden move the needle at all on some of these outcomes that we think are important? We actually teach some workshops in Atlanta here for community-based organization leaders on how to use this data portal to be able to understand better the health status of their own community and to actually take the pulse of their own community on a regular basis to see if what they're doing is working. So we're trying to figure out how to do better care in the clinic, in the community, with the outcomes data, but more importantly, we're trying to connect the dots between clinic and community and bringing these together, trying to get the outcomes data feedback loop back to the clinicians, back to the community, so that everybody is in a rapid cycle improvement process where you can see if what you're doing is making a difference and whether you can move the needle on outcomes and actually get us to diabetes health equity in our own community. Connecting the dots, managing the arrows, not just the dots. Now to do that, most of us who are clinicians have to get off the hamster wheel. We have to quit just run from exam room to exam room in a reactive mode and seeing what Mrs. Jones is here for today. But none of us can do this by ourselves, and none of us know how to do all of it. And so we need to get together in a learning collaborative and figure out from people who have solved some of these issues how we can apply them to our communities, and then learn together and grow together in terms of how we can build out this full three-element model with all the dots connected in a rapid cycle feedback loop. None of us can do it together, and so we are indeed all as angels with just one wing, and we can only fly when we embrace each other. With that, I'm going to stop, and Sabrina is going to tell you a little bit more about that learning collaborative.
I unmute my microphone.
That'd be a good thing, and I will mute myself in a moment.
There were
questions you wanted to take?
Well, I was going to say if you could just respond to the comment from Christy Woodard. I think I've addressed the question that Brenda had as well as Raquel. So.
Okay, maybe you could read me that question because I may have not. I've already scrolled past.
Okay, it's a comment, and it's from Christy. Glad to see your slide on cultural relevance and cultural ownership and Alaska Natives. I work for the VA and with tribal veterans and a work group RE, the VA Indian Health Service. I would like to see data on American Indian, Alaska Natives in your slide rather than lumped into other. We have a high prevalence of diabetes in Indian country. For tribal vets, there are cultural resources and for some military exposure leading to a service connection for diabetes.
Absolutely, you're right, and I'm sorry. I stole that graph from the Agency for Healthcare Research and Quality's National Health Disparities Report, but clearly there are lots of groups that are not well represented in the traditional graphs that folks publish. Another area where there's clearly a challenge is in the way that Asian communities are typically lumped all together as one group called Asian. We've actually published papers on the differences in cardiometabolic risk factors and diabetes outcomes or cardiac outcomes in people of various groups of different national origins who are lumped together as Asian in the racial ethnic groupings. And similarly for American Indian and Alaska Native, there's a lot of within-group heterogeneity there, but also the group itself has specific challenges in diabetes. And so what I would encourage is for each of you, first of all, thank you for reminding me of that, but also each of us are going to have to try to figure out what are the ways in which the recommendations we make need to be adapted and revised and sort of brought into culturally relevant modes and formats for each of our own unique communities in all of their diversities and heterogeneities.
There is an additional comment and question, and then I had a comment that it just goes back to your point about allowing the community to be involved, to allow them to show us how to care for them, and then we are the most culturally relevant that way. So
right. So partnership is important, and it's I think worth noting that example of the South Central Foundation, that model was built out after Alaska Natives took over control of that organization from the Indian Health Service. When there was community ownership, so it's not just us allowing the community to participate as if we have that power, but really seeking to turn over control, to let go of some control, and to make sure that there's real ownership, that we are truly equal partners when we're building out these models, and that requires some governance structure sometimes. Sometimes it just requires good humility and humanity. But in every case, the community needs to have not just input, but control and sort of co-guide all of this so that ultimately we are doing collaborative care for our communities as well as for our individual patients.
Right. Okay, there's a question from Linda. How could current reimbursement model be addressed to support shared medical appointments and other innovations in delivery of health interventions?
That's again a great question, and it's in the bucket of if I were running the world, all the things that I would like to change about the way we reimburse care. To the extent that some communities are going to begin moving faster than others into this world of accountable care organizations, or into what people refer to as value metrics rather than volume metrics. In other words, my productivity as a primary care clinician is often measured by how many visits I do, how fast I can make that hamster wheel spin, how many exam rooms I get in and out of each day, and how many people I saw. It's pretty clear to most folks that has nothing to do with health outcomes. And so when people start paying for value, and even in business terms, that means decreasing inpatient bed days and emergency room visits and the costs associated with those, which are really the high cost items in the system. And that happens to match up with adverse suffering events that humans have, because going in the hospital or going to the emergency room is usually a bad day. When we start paying people to improve those outcomes, then you can begin thinking much more creatively about the processes of care and how we organize the team. Does this really require an in-office visit, or could it be handled with a phone call and some communication over an e-portal? Does it require me to be the one who does the communicating? Or would the education actually happen better with a peer counselor from within the cultural group or within the community who has diabetes themselves, understands the community realities, and also understands diabetes, and could be a better educator than I could be in that moment? So as we begin to think about getting paid for outcomes rather than getting paid for volumes of visits by certain providers who have a billable, ID number, then I think we start moving in the right direction. And there are places where that's happening. In places where it's not happening, some Medicaid programs have become a little bit more creative about either funding care management fees along with the fee-for-service stuff, or some payers are beginning to pay a little extra for people who get all the way to a patient-centered medical home. And some Medicaid programs now, actually most Medicaid programs, will pay for a mental health visit and a clinician visit in primary care on the same day in the same facility. It's just that the clinicians don't know that or don't believe that, and so they don't bill it that way. But we've been reassured by CMS and by most state Medicaid programs that that actually isn't the barrier that everybody thinks it is.
Right. There's one more question for you, and then the other ones kind of pertain to the Learning Collaborative. How did you get the clinic admin to buy into the standing order for the A1C? It's obviously an investment. What convinced them?
Well, that's a good news, bad news story, and so the work is ongoing. The good news is we convinced them because it seemed like a worthy project. We actually had a little grant money to pay for the initial purchase of the cartridges, and we were able to demonstrate that it worked. We also were able to demonstrate that both clinicians, doctors, nurse practitioners, and so forth, as well as the nurses who are the ones doing the finger stick and actually in that case running it through a little machine, the DCA 2000 machine. We were worried that the nurses wouldn't like the project because we thought that it was extra time. They weren't just doing a finger stick blood sugar, they were also doing a finger stick A1C. That was extra time when they were trying to get patients in the exam rooms. But what we found was that they had been spending huge amounts of time trying to call patients back for abnormal A1C levels. 30% of the patients never came back in after that initial A1C level. We would find things in the charts, called patient again, no answer, left message, sent registered letter, sent security out to go get them. I mean, they were just doing these heroic efforts to try and get patients to come and get that A1C taken care of, and still 28 to 30% never came back for that visit to deal with the elevated A1C. So what we found was when we did surveys after the project, the doctors and the nurses loved the project, felt like it both saved time and made the care and outcomes better. The bad news of the story is that there was a financial person who understood none of that, who made an executive decision that buying cartridges cost too much and they were going to stop doing it. This was even a bad business decision, I must say, because you can bill for those A1C levels. 2/3 of their patients had either Medicaid or Medicare, a third were uninsured. But if you round the numbers on a what-if kind of basis, you actually would have been able to bill enough for the A1Cs that had coverage that you would have covered the cost of the program, and it made the clinicians happier, made the nurses happier, and the patients got better care and outcomes. And yet, they stopped doing it when the grant project was over. So, good news, bad news. Everybody on this call, don't behave like that, okay?
Right. There are two questions about the collaborative, which we'll address at that section. There was one from Raquel, where she asked about advice on how to find peer educators or how to train people. There's a wonderful organization that we're in partnership with called Peers for Progress. It's a national organization, and they have all kinds of resources on even training curricula. We also do have a best practice story on our website that's on a clinic called Alivio, and Peers for Progress had a promotoris program at Alivio, which is a clinic in Chicago. So I'll invite you to see that. We have tons of resources also too on our website, curricula, even how to advertise for peer supporters, the training. And I will say too that there is a national movement to provide more standardization for peer support, for peer training and training curriculum, certification even. So, and then now that I think about that too, we do have an on-demand webinar on our website that the leader of the Peers for Progress organization presented a few months ago. So, and that website is www.diabeteshealthequity.org. So, all right.
So the other, jump in, if I could, Sabrina, one other question I see up here about what tools or mechanisms exist for data collection and feedback loops. I will just say that, you know, that's a dream that everybody thinks health information exchanges someday will solve all that, the interconnectedness of all our electronic health records. I would say for most of us that reality has yet to happen. And so this often is really a negotiation, figure out who's got the data and how you can get it. Many hospitals would love to work more collaboratively with the primary care practices, and particularly if you have a significant number of the uninsured in your practice, and you help them understand that you're going to decrease their uninsured care load, what they think of as their indigent care load, or their bad debt load, if they're being particularly cranky about it. If you can help them understand that a feedback loop would help you to move the needle on those numbers, and ultimately would also help position you all for a collaboration around maybe an accountable care organization, then hospitals may be very willing to share, and they're right on top of that data about emergency room visits and hospital bed days, for example. And I think that's probably going to be a quicker way to get there than waiting for the magic HIE to cover all providers in an entire region. That day will come, but it's not tomorrow. And then the other group is payers. If your state Medicaid program, Medicare program, if your Medicaid HMOs or care management organizations, any of those who have data on those kinds of outcomes that they track regularly, those would be the kind of people that you want to sit down with and see if they'd be willing to share that data on your patients. And finally, if nothing else, start feeding your own A1C data back to yourself in an aggregate form as well as the individual form. I can look up an A1C on any of my patients, but knowing what the average A1C is for all my patients, and particularly knowing what % of my patients have really high A1Cs that are trouble, 9s, 10s, 14s, is really important information and begins to get clinicians to begin thinking about panels of patients and how are we doing as a practice rather than how is Mrs. Jones doing just by herself.
Mm-hmm. Thanks, Dr. Rust. If there are additional questions, we can entertain them at the end. So my portion of the presentation is to give you an overview of the Learning Collaborative, and I've simply just titled it the what, the how, the why, the who, and the when. So first, what is a Learning Collaborative? And I've described it as a systematic approach to improvement, and it's for a defined period of time. It involves best practices. So the things that we want to bring to scale nationally are best practices. It involves team-based learning and sharing. It involves testing and then implementation of systematic changes. We will be measuring the impact. And then our main thing is it's a method to close the gap that currently exists in diabetes-related outcomes. So what's the proposed aim of this collaborative? Our ultimate goal is to create or to improve a system of care that is person-centered, that's coordinated, and quality measured. So over a period of 12 months, the PDHE 3-element Diabetes Care Collaborative Partnership, we've got to find a shorter name, where our teams will consist of a clinical entity, a community partner, and an external outcome data source. And together they will work to implement the missing third element and build a seamless process of organizational coordination. So I think earlier we had a question about what role does a community health department can play in the collaborative, or what about a dietitian? Both of these entities can be a part of a collaborative. It's just a matter of what other entities will you partner with. We actually have a best practice story on our website of a community benefit where a hospital reached out to a community health center and a public health department to do a diabetes self-management project, and it's in Prince George's County in Maryland, where the hospital reached out to them, and through the through the public health department, they contracted all of their diabetes care all over the county, and it was a great story. They're still having much success, and I think the project has been going on for about 5 years now. So as Dr. Russ mentioned about a payee source and also a data source, the hospital had the data and they wanted to do something about it, so they used their community benefit project in order to address the diabetes numbers that they had in Maryland. So perfect example. So together the teams will make and measure changes in a rapid cycle to ultimately improve the health status and outcomes of individuals who have diabetes. So how will we accomplish this? What we're proposing through our Learning Collaborative is to assist organizations to adopt and improve clinical care, to improve clinical systems and clinical processes. We want to assist in helping to build community partnerships and collaborations, to help define and adopt effective data and collection of data, to help establish methods of multi-agency communication, as well as effectively use clinical information systems, whether that's HIE or simply using a fax machine. But how can we get the entities to be able to communicate and share data back and forth? So what is the design of this collaborative? This schematic is based on the IHI Breakthrough Model of Improvement, which is what our collaborative is based on. So throughout the 12 months, which will begin on September 1 of this year, it'll kick off with an in-person learning session meeting that'll be here in Atlanta for a day or a day and a half. And it'll be followed by, and at the learning session, teams will get together, we'll set the aims, we'll give the task, and teams get together to begin to craft the project that they're going to attempt over the next 12 months. That'll be followed by a 3-month action period time where teams will need to meet together to work that through their organization. During the times in between the learning sessions, as a method of support, you will have monthly calls with the entire collaborative, as well as with your mentee, your mentor, which is your faculty advisor. And then you'll be required to also do some monthly metrics and reporting. Then that'll be followed by a second learning session, which will be followed by the action period. And between action period 2 and 3 is where we like to begin to see the PDSA cycles take place, where teams have clarified their goals and their projects enough that you can begin to implement small tests of change to see what actually is working in your organization. So why join this collaborative? What would make a group want to participate? I guess this is a great time to say that our collaborative is free of charge. IHI hosts collaboratives year-round, and it's always for a fee. Well, this learning collaborative, although based on IHI, is free of charge. However, we will not be providing any kind of funding that will be necessary to support your systematic or your organization changes. So the onus and the weight of the changes that you'll need to do internally will be borne by the organization. So then what would be a reason for you guys to want to participate in what we're offering? Well, for one, the rapidly changing healthcare environment. I think Dr. Russ talked a little bit about reimbursements moving towards from fee for service to quality. Fee for quality. And so all of us are being called to practice more quality-based, but not just because we think so, but because we've proven so. So participating in this learning collaborative will help you to design and to build the infrastructure necessary to get to that change. The need for quality-based healthcare, not only because it's now being required or mandated from the federal government, but because research is showing that quality-based healthcare is how patients do the best. Participating in this learning collaborative will help provide for your organization the redesign that's necessary. I'm a clinician, Dr. Russ a clinician, and many of you out there are clinicians. And let me just say what we're all thinking: change is hard. We've been educated and we've been practicing all this time on a different model of medicine. But we need to move from siloed care and move towards quality-based, more collaborative care for our patients. So participating in this collaborative will give you the opportunity to be mentored through those changes for a great start. And then also to position you for funding. I'm not sure how many of you out there are currently grant supported, but if you look at the CDC website right now, you'll see that most of the funding now is trending towards partnerships and collaboration, particularly with community organizations. So participating in this collaborative gives you the head start, the jump on getting that infrastructure built. And then also, too, for a lot of grants, they want you to have already demonstrated that you started to make some changes towards that direction. Our Learning Collaborative is a perfect example of a way that you can begin that process. So who are we seeking? What's our ask today? We're looking for faculty mentors. We want subject matter experts who are subject matter experts in care coordination and clinical diabetes care. We want those of you who are involved in clinical transformation and you've made some strides. We want those of you who know about community partnerships and engagement and have started that process. Those who are into quality improvement and you've even been able to do some reporting on the changes that your organization have made. And also those of you who have an expertise in medical data collection and analysis. As we've been doing this over the past year, the most questions that we get are about data. What data should we be measuring? How do we harvest it? And then once we have it, what do we do with it? That's going to be a very important part of our Learning Collaborative. Also, who are we seeking? Not only are we looking for faculty members, but we're looking for teams to participate, to apply. Right now, we're only going to choose 15 to 18 teams. These teams we want to be made up of at least 3 organizations. 2 of them we'd like to have you already making some strides on integrated care. So whether you're a clinic that's already has some community partnerships, or you're a community organization that's looking at the data and you're planning some interventions for your community, then that's who we're looking for. So 15 to 18 teams that represent different vulnerable populations in various geographical areas across the country. We want to make sure that we have a good representation of the communities that we're concerned about. So not just African Americans. We are looking for those Alaska Natives and American Indians. We're looking for Hispanics. We're looking for people who are in rural areas who have low access to care or who have a low literacy rate, who have problems with transportation. Those are the kinds of groups that we're looking for, both in rural areas and in urban areas. We want you to have a lead organization with at least 2 partner organizations or a diabetes or a health equity coalition as a lead. And as I stated earlier, we want you to have demonstrated strength in at least 2 of the 3 elements. So an example that I use is like a diabetes coalition that may consist of a FQHC, it may be a local YMCA, health and wellness coalition, and a hospital that's sharing data through a diabetes registry that the clinical entity and the community entity has access to, so that we can look at these patients that are part of that community as a whole, that as a group we're going to manage these patients. So when will it begin? The collaborative dates are September 1st through August 31 of 2016. Applications will be made available through our website on March 31. After the applications are released, we plan to have a weekly Monday conference call to answer any questions that you may have to help assist you in filling out the applications. They will be due by May 1st. By May 31, we will make a decision announcement of which 15 to 18 teams that we've selected. And then on September 1st, the collaborative will begin. Now, between June 1st and September 1st, those organizations that are chosen will have what we call pre-work, because you're going to have to get your organization leaders to buy in. So there'll be some structure that you'll need to complete in getting your teams together and job descriptions and making sure that everyone knows the role that they will play on the transformation team. So, in a nutshell, we need you. We need you to apply as faculty. We're looking for 3 to 5 faculty members that will serve as mentors for these 15 to 18 teams that we're raising. As faculty, we want you to have some expertise in one of those 3 areas, to have demonstrated some success in your organization, as well as be apt to teach and have a passion for people and a passion for change. As faculty members, a stipend is offered. Your time commitment will probably be about a day, a month in total that you'll need to be involved with this project, mentoring another team. And then we need you to help us with participant referrals. If you are a group that's representative of a community that would like to apply, we'd love for you to. Or if you know of a group who you think will be a good fit for this collaborative, then we'd like for you to send them our way. So with all of that said, let's entertain some questions. Dr. Russ, would you like to come back on? Okay. So,
why, there I am.
Okay, here you are. Okay, I think this may be comments. So does anyone have questions concerning the collaborative, its setup, what we're looking for, or how you can apply? Oh, there's a question.
I see a question here about the National Association of City and County Health Officials. And so we haven't really mentioned public health departments as much as we should have. Certainly CDC looks to them as important partners.
Right.
And CDC, I should say, as well as many public health units around the country, I think are really beginning to see the necessity of bridging between traditional public health and traditional medical care settings, and figuring out how to, instead of competing or looking at them as doing different things. There used to be this notion that one does wellness and primary prevention, the other does sick care. I think we're having to stop using language like that and really move in the direction of how can we work together, particularly in the area of chronic disease outcomes, so that the medical care system and the public health system are closely working together. So we'd be eager to have follow-up conversations at a national level with the organization, but also would be interested in public health units. If there are public health units that have this ability to draw key stakeholders together, hospital and primary care folks and community stakeholders, and it's the public health department that is a natural convener of all that, fantastic. In some communities that's not the case, and so someone else would need to be the convener. So we don't want to prescribe which model is right for your community.
There was a question about U.S. territories being eligible to apply. I would say yes.
Absolutely, and if I can visit Guam, that would be good.
Yes. Maybe that's what we can have a second.
I do have a dream of doing that someday, so I'd be glad to help out there. But yeah, and I think anybody in the U.S. Broadly defined.
Yes. And then what part of the country is appropriate? As I think I stated earlier, we are wanting to be representative of diverse communities, so any and all parts of the country. We want to make sure that we have a good sampling of the patient population that we're concerned about. So, all right. So what do you mean by external outcomes data source? I probably didn't phrase that the best way, but I mean, okay, as an entity, say a FQHC, you do have your own internal data. We're more meaning like, say, a hospital that can give you data on the number of diabetics that came through the ER or the number of diabetics that were admitted. So that's what I mean by an external data source. How much of what's going on outside of the clinic are you aware of? That's the missing piece, and we want to use this collaborative to help bridge that gap so that we're giving patients more holistic or more total care, since we do know that they live outside of our exam rooms.
And if I can just add to that, that's an area where the public health units can be very helpful as well. State health departments, I know in our state, they're the ones who created that OASIS website, which is wonderful, but also they capture, they receive 100% of the emergency department visit data for the state, including all the uninsured folks who are usually hard to kind of capture. They also capture all of the hospital admissions and discharges. They can't tell me who the individual is, But if I need to know in a specific zip code, what is the diabetes emergency department visit rate for uncontrolled diabetes, we can do that. We can do it for hospital admissions. Usually there's a bit of a lag time. If it's going from the hospital to the public health department, they're massaging the data a bit and then cleaning it up. There's a bit of a lag time on that, and that's why I sometimes emphasize, working with your local hospitals to get better access to more rapid cycle data. But I know in urban areas it actually can be problematic that you may have 17 different hospitals that your patients could wander into their emergency room at any given moment. And so just having a data relationship with one hospital isn't going to do it for you. And that's where the public health surveillance system, and particularly those states that do capture hospital discharge and emergency department visit data, could be very helpful. Also, I'd suggest working with your reference lab, whoever you send lab data out to, Quest or LabCorp or whoever it is. Often they've got web portals where I can go in as a clinician and get the lab result on Mrs. Jones. But they also have ability to massage that data at the practice level and feed it back to you. And so looking for those kinds of tools would be useful. In addition, you can begin thinking about how to create more useful tools from your own electronic health record. If you're getting that A1C data back into your own charts in the electronic health record, can you create a dashboard that lets you pull up, the aggregate results for all your patients, and then identify specific patients who need more targeted interventions?
Great
question about international teams here, I see as well, and of course well, I don't know. The Bristol Myers Squibb Foundation had been funding diabetes-related projects in the Together on Diabetes program in India and China. My understanding is the foundation is shifting away from diabetes projects, so it will be left to the rest of all of us to try and see what we can do to be helpful in that space. We'd be open to and eager to pursuing how we could be helpful. I think for this learning collaborative, just because we do have a tiny shred of humility, we're going to limit ourselves to U.S.-based communities for the moment. But I think if someone has a suggestion about ways that we could form partnerships in the international settings, that would be exciting to me. We'd love to have those conversations.
Right. And the good thing about this being our first collaborative is that we don't know where it'll lead. Collaboratives are an all teach, all learn kind of environment, so it's a wonderful time of discovery. We do have our aims and our goals of what we are attempting, but we discover wonderful things along the way. So after these 12 months, the possibilities are limitless. So. And I will say too, for any of you participants who would like to do it, but you're just not sure that it may be too much work, or you may not be able to get the team together, let me just encourage you to try. We have this model works. It absolutely works. Integrated, coordinated clinical care with community support using data works. And it can work for you. So let me just encourage you to apply and to do the ask for those organizations that are around you, and let's just see what we can discover together. So.
Great. And don't be afraid to send us comments or questions. Sabrina Jackson, Michelle Wimbush, all of our team here would be eager if you're just not sure and want to talk it through with someone. We'd be glad to have those conversations.
Great comment. So thanks, Dr. Russ. So thank you, everyone, for attending. Just a few announcements in closing. If you would like additional information or would like to join the Learning Collaborative, please provide your name and email address in the box in the lower left side of the screen. If you know someone who needs to hear this information or feel like you would like to hear it again, We'll host another informational webinar on Wednesday, March 4th at 1 p.m. Eastern Standard Time. If you know of anyone interested, please spread the word and have them visit our events page to register. And our website is diabeteshealthequity.org. The links on this slide is live, so feel free to click and take a moment to view our collaborative page. We have a wonderful infomercial that we've designed to give you information. So as a final reminder, here at the Partnership for Diabetes Health Equity, we aim to serve you as a national online resource center, as a training center, and as a virtual community. If you have needs, ideas, comments, suggestions, questions, please do not hesitate to reach out. Take a few moments to look at our website to get acquainted with who we are and what we offer, and remember that it's only together that we can achieve equity. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol Myers Squibb Foundation Together on Diabetes Initiative. A special thanks to Dialogue for Health for helping us with our promotion and marketing of this event. Thanks everyone for attending, and have an awesome rest of your day.
Thank you, everyone.